طيب سكرين موجودة صح؟ طيب let's switch gears للمانجمنت ابروach. اول شيء قبل ما ادخل بالموضوع, did you find the lecture today a little bit different, يعني more kind of a lecture more than a tutorial, ولا ما سوينا شيء the previous two lectures؟ ما في كومنت. مستحيل الشباب. طيب يعني الستايل اليوم يمكن انسب. طيب هذا اليوم الليكتشر about the GI. Those are the objectives. طبعا الTNM classification is a very common, guys. It's still actually heavily utilized, but you have to understand that a lot of the oncology now, like cancer based, they started to move a little bit from this classification, but the concept of the classification is still actually true. Okay, so about the extent of the disease, we're talking about at the histology level, we're talking about lymph node involvement, as well as the presence or absence of metastasis. So even some of the specific cancer, they moved away from the TNM classification. It still holds some of the truth when it comes to prognosis and the treatment option. Okay, so when we talk about cancer treatment, really a classic three option were chemotherapy, surgical intervention, as well as radiation oncology. Okay, nowadays we started to see more option, things like biologic treatment, hormonal treatment, or even targeted therapy. Those now considered as part of the it's a kind of specific chemo. They are not classic chemotherapy, but they are under the umbrella of medical oncology. Okay. But why we are talking about colorectal cancer first? This is actually the percentage of colorectal cancer among Saudis, and you can see that there is a rise in the colorectal cancer since 1994. Anyone can guess or tell us why there is a rise in the colorectal cancer over the last 25 years? Anyone can have a guess?
عشان صار عندنا investigations كتير screening دكتور.
Good, good. What kind of screening? What kind of screening or investigation you're talking about?
الstool screening.
Okay, that's fair. I would say in general there is more awareness about the colorectal cancer, but also the rise of the screening with colonoscopies. Okay, and we're going to talk about that shortly. Okay, so there is a good chance that this rise is actually by early detection, because we are trying to find the colorectal cancer in early stage so we can actually treat it. Okay, so this is the recommendation from the American Cancer Society. Our recommendation is not far away from that. So between age 45 to 75, get screened. This is for everyone. Between 76 to 85, it's a kind of depend on other risk factor and the overall expecting life length, and between 85 should no longer get colorectal cancer. So you can remember from 45 all the way to 85, probably they should get screened. What are the options? Well, we have stool-based testing, and we have visual exam, and the visual exam can be through classically the colonoscopy, but also the virtual CT, which is the colonoscopy. CT colonoscopy is also an alternative. And there is some sort of a mixed option, like you can do sigmoidoscopy, like just looking at the sigmoid, as well as stool-based. It's a kind of combined test, okay? So when we talk about CT colonoscopy, it's actually become more and more being used and utilized. It's more convenience for a patient than the colonoscopy, but we also have to understand some of its limitation, okay? So it's mostly being used for diagnosis. You cannot take a biopsy through the CT colonoscopy, okay? But also it's not sensitive enough for those polyps less than 1 centimeter. So the small polyps less than 1 centimeter can be missed by the CT colonoscopy. So what are the symptoms for colorectal cancer? Well, change in bowel habits, abdominal pain, nausea, vomiting, especially when you have obstruction, gas and bloating. And those are considered as symptoms and signs of colorectal cancer. But we also can have fatigue from iron deficiency anemia, because we talked about occult bleeding, yani a heading, a bleeding not obvious in the stool, but it's been going on for a chronic time from cancer. So fatigue is one of the anemia symptoms. Loss of appetite and weight loss, those are general B symptoms, can happen with any kind of malignancy. Well, I'd like us to shine the lights toward the difference between the right side colon cancer and the left side colon cancer. Generally speaking, the right side have worse prognosis, and it's actually biologically different. Okay, so the biological origin of the right colon cancer is different than the left colon cancer. And for that, even the treatment option, I'm talking about the target treatment option, the biologic treatment option can be different between the two. But also the symptoms can be different, because imagine if you have a left side colon cancer, you will have some change in your bowel habits. Comparing to the right side, usually they will present with iron deficiency anemia or, for example, discomfort in their right side. So the right side, usually, that's a kind of chronic problem like iron deficiency or pain or losing weight, while the left side, usually they will present with change in their bowel habits. They may actually even have hematochezia, which is bleeding their rectum. Okay. So what are the investigation for colon cancer when you suspect one? Well, full colonoscopy if it is possible. You do a contrast enhanced CT looking for metastasis basically, and you can check the cancer markers like the CEA. For rectal cancer, they may require rectal MRI or endorectal ultrasonography to see the extent of the rectal cancer. So what are the stages? We have 4 stages. The stage 1 is the simple one. They just have cancer. It's not fully invade a thickness of the bowel. There is no lymph nodes involvement, no metastasis. While stage 4, it's basically a distance metastasis, and 2 and 3 is basically in between. Okay. How about the rectal cancer? Rectal cancer is more complex when it comes to the staging as well as with the treatment. So we lump them together because they share a lot of symptoms, but when it comes to the treatment, they are slightly different between the rectal cancer and the colon cancer. So, for example, when you have stage 0, of course, surgery is the option. When you don't have any metastasis in the lymph nodes, no metastasis distantly, of course, the surgery usually going to be preferred. When you move with stage 1, you started to use surgery, but also with possible chemoradiation, especially if you started to invade the circumference. When it comes to stage 2 and 3, there is a certain several options. It's really complex when to choose this and when to choose that, and this is why usually would be a multidisciplinary decision when the surgeon, radiation oncologist, as well as the medical oncologist sit in the table and discuss about the best options for the patient. When we talk about, for example, liver mets, still from the rectal cancer, still the surgery is still an option for liver mets, as we are always looking for cure. While when we talk about stage 4, we become talking about more about the chemotherapy as well as the palliative therapy. How about the colon cancer? Again, it's not far away from the rectal cancer, but we would see the surgery being always the first option in stage 0, stage 1, and stage 2. Compare this to the rectal cancer, where in stage 2, we may entertain using preoperative radiation. Even in stage 1, we may use chemo radiation. But colon cancer is heavily rely on the surgery when it's in the early stage, but once it's reached stage 3, you would use adjuvant chemotherapy. Once it's reaching the stage 4, we're talking about chemo and targeted therapy. Again, with the liver mets in particular, surgery can be also an option. So in general, the colon cancer, the surgery is a preferred choice in early stages. We're talking about stage 0, stage 1, stage 2, and then with 3 and 4, we would use surgery as well as chemo or sometimes chemo radiation. Okay, you don't have to remember يعني by heart chemotherapy and their side effect. I think it's beyond the scope of this lecture, but it's good to know at least some of the names for the chemotherapy, because some of them are heavily linked to a certain kind of malignancy. So whenever you hear about Volvox, that's usually a treatment for colon as well as rectal cancer. So this is a region like a chemotherapy region for colorectal cancer. Okay, so what to do after after a treatment, whether it's surgical or after the chemoradiation or after surgery and chemoradiation? We do what we call it secondary prevention. Okay, it is a kind of post-operative surveillance, and this can last up to 5 years. And we do it by checking the CEA, which is the cancer marker, every 6 months, as well as doing an annual CT scan up to 5 years, along with, of course, the colonoscopy. So the colonoscopy, and this is a very tricky, some people, we cannot do a full colonoscopy at the time of diagnosis, okay? Because when we do the colonoscopy, it gets stuck in the cancer area. Let's say they have a left side cancer. So for those people, after the resection, we always advise to do a colonoscopy after 3 to 6 months after the resection, to make sure that we don't have any polyp or any early stage cancer in the rest of the colonoscopy. Is this, guys, clear? Okay, so some people, for technical issue, we cannot do a full colonoscopy at the time of diagnosis. ممكن يكون عندهم الكولون كانسر، يكون عندهم مثلا بالليفت سايد ولا بالترانسفيرس كولون، وبعدين هذا إذا جو يسوون الكولونوسكوبي, the colonoscopy gonna get stuck, so they cannot do a full colonoscopy. هذول الناس after surgery, after a tumor surgery, 3 to 6 months, we do a full colonoscopy to make sure that there is no other cancer in the ascending colon in the right side, ولا polyp or anything should be removed. وبعدين after that every 3 years. الناس اللي نسوي لهم full colonoscopy before surgery, they just have to do a colonoscopy every 3 years. Okay? طيب. Any question about the colon cancer, guys, before we move to the next cancer? طبعا بعضهم يسأل وش المطلوب مننا, what should we do? يعني you always go to the objectives. It should be clear. يعني in this lecture مثلا understand a diagnostic testing, their limitation in the GI malignancy, ليش نطلب التستنج هذه, understand the cancer staging as well as management when it comes to يعني surgery option, chemotherapy, radiation therapy, as well as the surveillance afterwards. Okay. طيب. Second kind of malignancy is pancreatic cancer, and this is very notorious cancer because it's linked in the public to having bad prognosis, basically. And the majority of the pancreatic cancer are adenocarcinoma in nature. This is a very good slide for me for one reason. It will actually tell you about what's the symptoms of the pancreatic cancer according to the site. Where is the cancer is actually happening? So for example, if the cancer is in the head, you would see obstructive jaundice. You will see dark urine and light stool. You will see some nausea and sometimes vomiting. Okay, compare that to someone having the cancer in their body of the pancreas. Usually they will have back pain and upper abdominal pain. It's like chronic pancreatitis. Compare that to someone have the cancer in their tail of the pancreas. So they will have some sort of indigestion because it's pushing the stomach. They will have pain after eating from the stomach extending and then reaching the cancer. They will have weight loss, nausea and vomiting, as well as lower abdominal pain. So based on the site of the cancer, you may have different symptoms. Okay. Okay. So what are the investigation we do when we suspect someone having a pancreatic cancer? Well, we do CT for the chest and abdomen. Alternatively, you can do an MRI to find the staging and treatment. If the tumor is localized, okay, if you suspect that the tumor is very localized because you did the CT and it's very localized in one of the area of the pancreas, you do what we call it laparoscopic ultrasound. So they do endoscopy, and then in the endoscopy, they actually put the ultrasound to see the involvement of the vessels, as well as if there is any MITs, is there any metastasis locally, okay? And then you also can take FNA, this is through the CT, for example, or you can take it through the endoscopic ultrasound. So what are the treatment? Well, the patient without evidence of metastatic disease who appear to have a technically resectable disease should go under resection. Don't forget that the pancreas is very large organ when it comes to the geographic. It's go from all the way to the right side of the abdomen, all the way to the left. So it can be sometimes technically challenged to resect the tumor, but whenever it's resectable and no evidence of metastasis, the treatment option would be actually resection. Okay? Patients who are medically well enough after surgery should receive chemotherapy. So basically surgery, then chemotherapy after surgery. Okay? For those with a metastatic disease, chemotherapy is the choice. Okay? So لاحظوا إنه ما في option of radiation. A word about the prognosis. When disease is unresectable because invading a critical vascular structure, median survival is approximately 1 year. And this is actually heavily linked in a lot of people in the public that the pancreas is having a poor prognosis, which held a lot of the truth. Okay? Any question, guys, about a pancreatic cancer? Pancreatic cancer, question. Or colorectal cancer, question. ها شباب، أي سؤال about a pancreatic or colorectal cancer قبل لا ندخل على ال other cancers؟ اسألوا قبل أن تسألوا. واضحة؟ Okay, that's reassuring. طيب، إذا خلينا نتكلم عن الأسوفيجيال كانسر now. Esophageal cancer. So overall, there is two major types of esophageal cancer. And above is notorious for squamous cell carcinoma. Okay, and if you remember, من the first medicine course, risk factors are basically smoking and alcohol ingestion. Okay, and this is not only for esophageal cancer, for even oropharyngeal cancer. So smoking and alcohol ingestion. Well, when we talk about adenocarcinoma, we talk about Barrett's esophageal, okay? And this can develop after a prolonged history of uncontrolled reflux disease, but smoking also is a risk factor. Esophageal squamous cell carcinoma, almost all tumor above the lower third. Hello? And above the lower third of esophageal is usually squamous cell carcinoma. Okay, what are the symptoms? Usually is dysphagia and can be painless, weight loss, chest pain, and hoarseness. Okay, worldwide, squamous cell carcinoma comprise about 90% of all esophageal cancer, but the incidence has decreasing in the Western country as the incidence of adenocarcinoma is rising. Okay, so when it comes to the percentage, squamous esophageal is common, but now there is a rise of adenocarcinoma, especially in the Western countries. So what are the investigations we do? It's kind of makes sense. We do an upper endoscopy to look for the esophagus, okay? And we take biopsy and cytology testing. We can do barium swallow, okay? To see what's the location of the cancer, as well as can help us with the staging. CT can identify METs, but actually endoscopic ultrasound can be even better than the CT. So usually when you suspect someone with esophageal cancer, a practical way of doing it is they do barium swallow to know what's the location of the esophagus. Then they do an endoscopy, GI, so an endoscopy, and they go there and they take biopsy as well as doing ultrasound at that area to know what's the staging. Those are the staging of esophageal cancer, as you can see, as well as the treatment option. Again, the same message. When you have it very early on, you think about surgery as that option, and usually it's curative, okay? But when we talk about stage 1, 2, 3, and 4, we are talking about a combination of surgery as well as chemo radiation. Well, this is, it's almost a pattern for a lot of malignancy. A surgery would be a good option in early stages, But once you reach an advanced stages, surgery can be an option along with chemo and radiation, and sometimes surgery is not an option at all, okay? But as you can see here, in all the stage cancer till stage 4, surgery still can be an option with the chemoradiation, for example, in stage 4. Okay, so surgery is the primary treatment of leukoregional disease. And then this is just kind of extra information that anti-HER2 monoclonal antibody can be added to the chemotherapy in cancer express HER genes, okay, which is like some of the breast cancer. How about the prognosis? Overall, the 5-year survival rate ranging from 15 to 25%, depending on the stage of cancer at the time of initial presentation. Okay. How about the gastric adenocarcinoma, which is sharing a lot of similarity مع lower 1/3 esophageal cancer. Well, a rate is heavily steady decrease since 1990s. 2 types of gastric cancer, intestinal type, which is the more common, as well as diffuse types. H. pylori is a risk factor for both of these cancers. So H. pylori is linked to hepatic ulcer disease. It's linked to gastric adenocarcinoma so far, and we'll talk about also a special type of lymphoma in the stomach, also linked to H. pylori. What about other risk factor? Well, for the intestinal type gastric adenocarcinoma, you have male gender, you have ethnicity, Asian, you have diet high in smoked and salted and pickled food, as well as nitrates, nitrites, and smoking and obesity. And to بعض الأحيان, one of the easiest way to remember those risk factor is to bear in your mind a classic patient, what we call it a classic patient. So you imagine, for example, someone from China, they are obese and smoking and eating, and he's male and eating a lot of salty and pickled food. So those are the classic risk factor for gastric adenocarcinoma. How about screening? Well, we don't have any recommendation for screening for population. So we only look for stomach cancer when we are suspecting it, when they develop symptoms. And this is very complex way to understand the screening, because when you do screening, you have to prove that doing a screening not only going to detect the cancer in early stage, but it's going to detect the cancer in early stage. It should change the outcome, and it will save money to the nation. So it's a kind of medical, but as well as economic factors that playing in any screening. What are the clinical manifestations of stomach cancer? Well, poor appetite, weight loss, abdominal pain, early satiety, nausea and vomiting. I think all of these symptoms can be explained by someone having a malignancy in their stomach. How the diagnosis is being made? Well, typically is by doing upper endoscopy with biopsy. Typically, those people will present with those symptoms. Those symptoms are indication for an upper endoscopy, and then when they do the upper endoscopy, they will see some sort of mass or lesion in the stomach, and they will take a biopsy. And usually, by the looking at it, usually it will suggest a malignancy. Okay, how about treatment? Well, surgery is the primary treatment for leukoregional disease, like the esophagus. And approximately 1/3 of patients, they will go through surgery. How about a neoadjuvant chemotherapy or neoadjuvant chemotherapy and radiation? This can be done before surgery, okay? بالنسبة للناس اللي they go through surgery, we may give them chemotherapy after surgery. فلاحظوا إنه radiation therapy, it's only an option before a surgery, not after the surgery. Okay. طيب. Few words about other GI malignancy. Any question, guys? Okay, so let's talk about other GI malignancy. يعني other حطيتها يعني إنه عشان نكمل الموضوع، لكنه really الميجر GI malignancy are colorectal, pancreatic, esophageal, as well as adenocarcinoma for the stomach. What did Steve Jobs die from? Anyone? ما زلتم متابعين؟ What PC أتصور إنه pancreatic cancer, huh? Which type? Okay, I thought to get your attention about this neuroendocrine tumor, or formerly known as carcinoid tumor, which ended to the death of the genius Steve Jobs. So it's rising from the endocrine cells within the digestive tract. So they are not adenocarcinoma in nature. I would like you to understand that although histologically they are similar, there is a difference between the GI and the pancreatic neuroendocrine tumor. And for that, they respond differently to a drug, okay? Most functional pancreatic neuroendocrine usually secreting gastrin, so it can lead to gastrinoma, and this one of the causes for peptic ulcer disease, as well as releasing insulinoma, which can lead to basically hypoglycemia. How do we diagnose them? Well, when you have a high suspicion for them, you can do a CT or MRI for the abdomen. You also can do endoscopy with ultrasound. You will see the lesion, or you do what we call it octreotide scintigraphy to detect small lesion. Octreotide scintigraphy is not available in whole hospital, okay? But CT, MRI, as well as endoscopy, ultrasound might be available in a lot of places. How do we treat? Well, for functional pancreatic neuroendocrine, surgery is recommended if more than 90% of tumor can be resected, okay? But if it is not resectable, you may end up treating them medically by giving them PPI if they have a high gastrin level, as well as somatostatin analog to suppress this functional tumor. Okay, some words about gastric lymphoma. Basically, this is heavily linked to H. pylori, okay? And the symptoms is resembling a stomach cancer, the adenocarcinoma, but the biopsy will suggest this mucosa-associated lymphoid tissue. And the treatment, so majority of patients, they may not need chemotherapy. nor radiation therapy. Okay, the majority can be actually treated by eradicating the H. pylori. Okay, so imagine you can actually treat cancer, okay, by just giving antibiotic. Let this sink in your mind for 1 second. هضمتوها يا شباب؟ We are treating cancer by giving antibiotic. But this is يعني really طبعا of course there's people gonna need chemotherapy and radiation, but I thought it's very trivial to mention يعني إنه eradicating H. pylori can actually cure patient from Malt's lymphoma. Okay. Last but not least, what we call it GEST tumor, so gastrointestinal stromal tumor. It's having a lot of genes abnormality. It can be anywhere in the GI tract, but most commonly located in the stomach, and usually they stay years and years and years before discovering the malignancy. And when it comes to a symptomatic patient, we are always aiming for cures. So we basically try to resect this localized GEST, but for high-risk tumor, we may end up giving them adjuvant tyrosine kinase inhibitor, which can be also used in some of the hematological malignancy. Okay. Okay. Question, guys.
الرير كانسر يا دكتور بننسأل عنها في الاختبار.
أي شيء يعني ذولي ترى أي شيء we mention in the شوف. Let's put it in this way, guys. طبعا I don't care a lot about the exam. I care about يعني what you're going to encounter in the future. هذا general statement. بس أي شيء نذكره بالليكتشر هذا أقل شيء لازم تعدي عليه. هذا أقل شيء. أنا بعيدها مرة ثانية. أقل شيء. That means you might be asked in the exam about things we didn't mention in the lecture. But it should be clear and the objective that this is actually something we're actually trying to accomplish. Okay? ففعليا لازم تعدي على التكست book you have and يعني have the general read about the topics. بعدين اللي بالlecture هذا الحد الأدنى. And honestly, the lecture is just to further explain and elaborate. هذا what's the academic lecture meant for. ما صعب تذاكر من السلايدات صعب جدا. You have to understand the whole topic وبعدين slides only highlight some of the topics. Any other question not related to exams? ها شباب أي سؤال؟ طيب يلا يعطيكم العافية جميعا موفقين إن شاء الله. بس خلينا ناخذ الحين فيدباك جايز. يعني نكمل على نفس الستايل ولا لأنه فعليا هذه it's more than a lecture than tutorial I have to say.